So the unbiased part of our project title really relates to this concept, this construct that relates to our measuring different characteristics of patients, so patient-reported outcomes, clinical characteristics of patients, functional, what patients can do, for instance, lung function, the cellular level, for instance, counting or assessing cells in different tissues, different compartments of the body, and down to the molecular level, where we're looking at the subcellular level of different substances that may be involved in the different pathways in the disease, for instance, inflammatory pathways. In days of yore, perhaps we have conducted research trying to understand patients with severe asthma. We've just focused perhaps on the cellular or molecular level, and we've perhaps just had a hope that we'd be able to identify perhaps one or two targets that we could modulate that would enable us to actually develop a new medicine that would be a benefit to patients. But we realized that severe asthma is, and many diseases are complex. There are multiple different mechanisms that are in play, and there's probably not just one or two things that we could measure to fully understand and characterize a patient. We need to look at the patient holistically, look across a range of different assessments, and look at patterns within these different assessments. Then, by looking at the patterns within the different types of assessment, then the powerful piece of U-BIOPRED is that we wish to integrate the data across this range of different assessments, so we ultimately achieve what we call a handprint, or a profile for a particular patient subtype. And we believe that will give us a more powerful approach to better identifying different subtypes of patients. So this is the concept underlying the U-BIOPRED logo, that will look for profiles across these different domains, so effectively different fingerprints within a particular patient's profile. And the integration of this is the handprint, the defining picture of a particular patient and different subtypes of patients within the disease. By taking this handprint approach, we'll aim to study patients, so a large cohort of patients, and to follow them for 3 years, and to look at how these different handprints can predict progression of the disease and can be associated with different patient profiles. We'll also be able to look at how patients with different types of standard therapy may progress according to their particular handprint, and also perhaps identify particular handprints that are associated with disease progression. And by taking this approach, then, as I mentioned before, we believe it should enable us to better identify relevant preclinical models to assess potential new therapies, and also enable us to conduct clinical trials in a more focused way, rather than taking a patient population with severe asthma that may have quite widely different characteristics. We'd be able to take a more focused approach by identifying patients with a particular subtype of different characteristics, and for whom, for instance, a particular new therapy could be more relevant for. And the patient cohort that we are including in our protocol includes both adult patients, children. We have 500 patients, adult patients with severe asthma, 100 children, 75 adults with mild asthma, 50 children with mild asthma. We intend to include patients with COPD, healthy controls, and also infants with severe recurrent wheeze and mild recurrent wheeze. So we believe that this really will be a comprehensive assessment of both adult and pediatric patients with the different types of severe asthma. And this is the biggest undertaking of its kind to date, and indeed I think the most sophisticated undertaking of its kind to date. In order to do this, then we've split the project up into different work packages, like you've seen with some of the other projects that have been discussed so far this afternoon. So we have a package specifically to coordinate and manage the project, because this is a large project which is looking across a number of different domains of the disease. We have a work package related to establishing diagnostic criteria, because we haven't got a unified, internationally accepted way of diagnosing and classifying these patients. So we've done already, the project's done a considerable amount of work in helping to generate a consensus, an international consensus on diagnostic criteria for severe asthma. Work packages 3 and 4 principally relate to the cohort, so the actual main patient study that we're going to pursue, including the bronchoscopic assessments in that. So that's an assessment to look at samples of lung tissue. We have a work package for human preclinical models, for preclinical animal models. And then all this, these different types of study will generate a large amount of so-called omics data, so a large amount of data from things that we can measure in different tissue compartments. And we're going to need to integrate all this data in the manner I described, so we're going to have to use sophisticated approaches to mine the data and understand it. We also have a dissemination work package, so that's really about communicating the activities of the project and making sure that other stakeholders, various different stakeholders, can be fully apprised of progress with what we're up to and can get involved and engaged in what we're doing, and also a specific ethics work package. Obviously, we've got a sophisticated consortium, a sophisticated project that obviously will include ethical issues, as we're including a significant patient study within it, and we have a specific work package for that. This slide I won't go into it in any detail, but it just shows the fantastic project planning that Scott and his company have been doing in terms of looking at the different activities that we need to execute. So I think it just shows the rigorous planning that we need to put into these projects in order to make sure they deliver. And the consortium itself consists of a number of different key stakeholders. I think it's very much within the spirit of IMI. We have 9 pharma companies from FPIA. The EMEA are involved. We have a representative on the Scientific Advisory Board. We have multinational industry represented. We have 20 academic centres that are included, SMEs, and patient and care organisations as well. And just to make the point that this is very much an EU-level initiative. So we have centres throughout the majority of the key European countries. And just to list the centres here, so we have the academic centres, the patient organisations, and I think, as we acknowledged earlier on, I think it was excellent that these patient organisations were referenced in one of the presentations this morning. When we wrote the call for proposals, we specified that we wanted patient groups included, and I'm pleased that all the expressions of interest, so the majority actually included patient representation, but actually U-BIOPRED, I think, has got the most robust, had the most robust patient representation across the different expressions of interest that came in. That's Philips Research as the industry SME, and then BioSci, Cyanogen, and Aerocrine, various different SMEs that are included. The point of this slide is to show you that for these different pharmaceutical companies that we have various different leads, but that all the companies are involved and they're very well integrated into the different work packages. Some are providing more in-kind resource and more funding to particular work packages than others, but each company is putting in a total resource commitment, comparable total resource commitment, and each work package is co-led by an FPIA and an academic colleague, and I think within each work package, and we've got excellent examples of where the different partners are all contributing in an excellent manner